So, thank you, Nora. Do we have any questions to the speakers?
Thank you very much. Just one comment about the guidelines. As you know, for the Professor Bremond-Gignac, as you know, one of the first country in Europe to have official guidelines is Italy. Since more than 10 years ago, the National Institute of Health prepared the national guidelines. So I am happy to see that also at French level and European level, more or less the approach is the same. So in the methodology applies is the same, but what is missed 10 years ago and what it seems is still missed in the European guidelines is one issue. Since we are listening to in 2 days that also about all the implication related to functioning of other organs and other aspects of related to the aniridia, particularly the endocrinological issues and diabetes and what else. And so perhaps we should, I don't know if there is already, but I would suggest just to think also to endocrinologists as one of the target of the guidelines, but also families must be involved and informed about that for two reasons, at least. On one hand, diabetes and all the disease linked are the one of the few diseases in which also the lifestyle can do something. On the other hand, I am a father of a daughter with a disability. We usually use food as a reward or compensation for other things that lacks. So it could be also a way to educate families to use different kind of rewards in order to give something to your sons, to your children. And that's
So thank you very much for reminding that Italy has, of course, guidelines. There is also Spain has guidelines. I think Germany, Sweden. I said about Sweden, but I didn't make the whole history because, of course, we are all involved, and it's really very nice. And of course, we included the problem of the endocrinology and diabetes and all of these. And it is of course very important. And we make the paper for progress, including a very nice endocrinologist specialist. And so we have the feeling it's very important, but it is very difficult to find the good practitioner interested in this. That's why it's sometimes very difficult. But thank you for underlining this. Thank you very much.
So, yeah, I have a question for I think it's Fabian. Let's see. Yeah, Fabian. So a couple of questions. One is a very easy one. So you mentioned there was a large vessel. It was treated prior to keratoplasty. Was that with diathermy, or what technique did you use? And then my second question, a little trickier. So you correlated, the number of glaucoma medications versus the stage of AAK. Is that correct? And it only went up, it looked like at one time point, but with 4. Probably the only significantly different point. But my question is, did you try, there was an adjustment for age with the other analysis that was done. And I think, I'm hoping you did that because there's a high chance there of an ad hoc ergo propter hoc fallacy or spurious association if you just do that graph with those two things, because age is another factor that could lead to, is well known to increase AAK, and is the strongest factor that's been found to correlate with worsening. And number two, the age is also a major risk factor for increasing the number of glaucoma drops. So I would say that, I'm used to getting attacked by cornea specialists, believe me. So we have to bring up this kind of thing all the time. But we get blamed. Our tubes are too close to the cornea. Then we do tube studies about where they're placed, and they're not related. And then everything we do is gets blamed. But I do think that in that case, you really have to check the age, association, because that could be a major source of a spurious correlation there.
Thank you for the question and for the comment. I would start with your first question about corneal transplant that had some preparation before the transplantation. And I did bring up on this case because it was a clinical application of the animal model I showed. So they used a combination of UV cross-linking and fine needle coagulation to regress the vessels. Yes, diathermy, yes. So I think that's the answer for the first question. Now for the second part, for the longer part, I had to shorten my presentation a little bit. I was told on short notice that I should compress it to 15 minutes. So actually we did correct for age. We also did correct for previous corneal surgery, and in the original publication you will find this data, and you will also find the adjusted graph. But yes, it's a very important point, and I just had to shorten it a little bit to be able to keep within the time.
Going back to the guidelines, the European, but not necessarily European guidelines, I would ask, and going back to Corrado's point earlier, is there any plan for European and maybe even global to have indications for families, but also including education for aniridia patients? Because I know in some countries it's happening already, but it would be great to have such a guideline. We are, and I see are several works done on the medical part, which is amazing. I think it's obviously the best, but it would be good because it was discussed here about the quality of life, and this is with a high impact on the quality of life of the patients with aniridia. Any plan on this? Maybe it started already.
Yes, there is also a plan for that. We can't do all the things at the all time, of course. There is European guidelines, as you have seen, and there is a part, of course, of help for families. But also we have questionnaire for quality of life ongoing, and so we have to wait a little bit more. And I'm so sorry, we can't do everything at a time. But it's a very good point, and we are working on it.
I have two small questions. I think it was you talking about aniridia is always bilateral. Is there any exceptions, or are they always bilateral?
They are all, to my knowledge, they are all bilateral. It doesn't mean that there is, for instance, bilateral iris anomalies, but they are all bilateral for some special features like grading of hypoplasia, macular or foveal hypoplasia, or a very small iris anomaly. And so I've never seen a unilateral congenital aniridia. I mean, purely unilateral.
And the other thing was about strabismus. You mentioned that. I'm a children ophthalmologist, so I've been working with that. I suppose, do you do surgery as well, or you do? Because I thought that was, wasn't that
well,
worse than the thing with
no. I do strabismus surgery when necessary. It doesn't mean that I'm going to operate every strabismus in congenital aniridia, but sometimes it's very useful because there is really, it's difficult for the child when you have, for instance, a very severe congenital aniridia with a severe strabismus convergent one, for instance. So I do. And I think I have improvement. And we published a paper on this, not exactly on the improvement after surgery, but we published the epidemiology also, and the how common the strabismus is there. Of course, we do not correct the nystagmus, so that's why it's complicated.
But what impact does it have on the cornea? No. Or?
No, if you must be very cautious when you operate the strabismus, because you need to be careful and to make all the lubricants during the surgery, which is not useful in a classical strabismus. But if you do this way, I did not observe in my patients operated a worsening of the cornea opacification.
If there are no any other questions, we slightly come to the discussion about, okay, the other question, but anyway, differences and similarities, management of aniridia in children. I think it's both together we can discuss now. The question is?
It's specific to the number of medications and the advancement of keratopathy. Is that just drops versus, or is that considering oral medication as well?
The study we showed was just considering eye drops.
Thank you.
You know, this is let's talk about it's challenging in children, I think, because we started examination of children in our center years ago, and then it was always a problem. When I joined this group in Hamburg, I've seen with Professor Barbara how to do it, but it's also a big challenge to make a really proper examination. So that's what Dominique said before. We usually do that in general anesthesia, and that's always doubt, because many also parents are in doubt. It is necessary if we couldn't do that without general anesthesia, and also we started with Neil to do that, even the confocal microscopy in our cohort of patients in Poland, children, and I think the younger was about 2 months old, and this is a challenge. And then, in my opinion, it is impossible to do that without general anesthesia to be properly done, especially the first examination after the birth. What is your Dominique? What is your opinion about this?
I think really it's important to have a real management with first examination under general anesthesia. To my thinking, you can wait a little. You can wait. I don't do that before 4 months or 6 months, because I think we do not want to take a risk of anesthesia. And I do this. And if you do it, you need to have the devices adapted for handheld for children. And so you can have the best management, the best quality of the examination during general anesthesia. I think it's important, but if it's not possible because it's too costly, if there is, well, the good examination with clinical examination is also very important. And sometimes ophthalmologists don't know what they are looking for, and that's a big problem. The best you can do is to have a general an examination under general anesthesia, to my thinking. But it's so easy in France because it's free of charge for most of the people. So I can't say that I'm part of WSPOS, you know, the World Society of Pediatric and Strabismus, and I can understand if you are in a country very far, that it could be so difficult. So we must think about that and try to get some answers, even if we cannot access to this.
Just one thing, because as Aniridia Europe, we were contacted by another patient organization from USA. They are dealing with this disease called multisystemic smooth muscle dysfunction syndrome. And they were asking us to promote the differentiation from aniridia, because many patients at birth have been misdiagnosed as aniridia because of the dilated pupils, and this has to something to do with anesthesia, because in this syndrome, anesthesia can cause a stroke. So this could be a misdiagnosis of this type, could lead to a fatal event. And so don't you think it could be useful to add this to, let's say, to the part of the guidelines in order to inform about this possibility? Of course, they mentioned the fact that this is an ultra-rare disease, but we cannot, of course, because it is quite common, it seems, from what they report to me, of course. This is a patient organization, as I said, not a clinician, that there will be many cases of misdiagnosed with aniridia. And this can be of life-threatening or postponing a correct, an appropriate treatment.
That's a very good question, of course. I think we cannot say that, yes, we need to read more about the disease, because sometimes associations, they don't know exactly about the phenotype. So we must be cautious, and I will be happy to read all the literature on the disease before saying, yes, we must add, or no, we have not, it is not useful. Because it could be just one line if it's necessary, but we must be cautious of that and be aware if it's really necessary or not, and if it was not, a mistake and not someone that do not know about aniridia. And so, but of course, it will be a pleasure to read that.
Dominique, just to follow up that, maybe you can say a few words about, that it's quite a strict protocol that has to be followed for the guidelines. And generally, I would say that everything has to be very much evidence-based and published and available in the literature. Yeah. Maybe you can say something.
Thank you, Neil. That's very important. That's why I told we need to read the publications. That's first. Thank you. That's good.
Regarding your study on the 300 cohort of patients, one of the conclusions was that if you do a surgery or glaucoma, the risk of aggravating is higher, correct? During the life.
Well, I'd say it differently, because the data we showed was not follow-up, but it was the stage at first examination time point. So we just had the data, how many eye drops are they using, how many active agents, did they previously undergo glaucoma surgery or other corneal surgery. So this data did not do a follow-up, did not track the stage of AAK and then stage of AAK after the surgery. The register will allow us to examine this data in the future. But right now the first publications we did was just the data at first examination time point. Okay?
Okay, thank you.
I think because it's always a big discussion about when to do the surgery, but glaucoma surgery is really complicated in aniridia as well, because we know about this fibrotic syndrome. And I have had a patient, pediatric patient on Tuesday actually, and it is our patient, but we didn't recommend the glaucoma surgery. The intraocular pressure was about 22, 23. Nerve was okay, and the visual acuity was 0.1, 0.2. It was a 17-year-old girl. And but I don't know why. She went to one of the private center in Poland, and they said, no, it is possible to do the surgery. And they did the surgery. And there was a big complication. And she was like, after 3 weeks, came to us back. And then we have a big problem now. This is hand movements, and there is a problem. There is a choroidal detachment, big hemorrhage, and big problem now. And we are really careful with the surgery, and it's not just about this keratopathy we are talking about, but in my opinion, this surgery in aniridia patient, glaucoma surgery, is always really danger, I think, even. So we recommend to do it. Professor Netland yesterday was talking about this mix, and I think it's also the new way now to start that. For example, in Poland, it's really difficult to do that because it's not refundable now from the government. But I think this is the another way to do that, because the classical glaucoma surgery, I think, is doing a lot of wrong things. Not even this aniridia keratopathy, but we have a lot of problems then, especially in pediatric patients, because in my opinion, we could still wait because there was no nerve damage and visual acuity was really good. And now we have a big problem. And I don't know what to do next. I will see her tomorrow, on Monday, and we will decide what to do next.
Yes, thank you. Just something else too. It's sometimes you have no other way to stop the glaucoma, so you need to perform surgery. But of course, and Peter said very clearly, first the medical treatment is the first line, and so sometimes you have to balance the treatment. So you have to operate the glaucoma because you need to operate, and you know that it will be difficult for the cornea, but you get the best possibility to keep the cornea with lubricants and everything. And that's why it's complicated, and that's why it's individual, it's customized for the patient. That's why I think it's very important to think and to discuss with the family also, to explain why we choose this solution or why we don't choose this one. And the problems come from practitioners that don't have the experience of this kind of pathology, and that's why it's complicated.
Can I follow up on that question? Because I remember in Venice, Professor Netland talked about which medication you would start with respect to glaucoma, and that is also, there is, as I understand, no consensus. If you compare to a normal child that gets glaucoma, you would usually use a certain medicine. But is there something specific which one should take into account when it comes to an aniridia child? What would your recommendation be today? I remember in Venice it was so clear, like you start with this and then you go with this and then you go with this. Wow, that was, but what would your recommendation be today?
First of all, you need preservative-free.
Of course. But
there is nothing else
about the
that we can tell. And it's also very complicated because you don't have all the patient. For instance, if you have a patient congenital aniridia with asthma, you will never go to beta blockers. So I don't have the solution. I'm so sorry, but maybe someone has, but I don't have it, and I can't tell you. But the most thing is. An analog of prostaglandins, beta blockers, and of course like dorzolamide or something. These three are possible, and I couldn't say the best one. I know what I do, but probably is not the good way. But I think it works well, and it depends also on the age. So when they are younger, I can go on beta blockers because we have simple treatment sometimes. And when they are older, I go to analog of prostaglandin. But it is not, this is not a recommendation. I can't tell that because it's not written, there is no study, and so that's just my feeling. And my feeling may be not the good one.
But maybe that's an idea for the next study.
Yes.
Just to help, the general practitioners to make this decision, because, yeah.
But it's quite simple. Looking for the pediatric glaucoma, it's quite similar.
I will follow up with the team. I just want to ask you, maybe any of you heard that there was a new drug presented for glaucoma from the Japanese laboratory, and they say it reduces pressure by affecting trabecular mesh. Do you have any news about this? It's true. Yeah.
So we are doing. I did a study on ROCK inhibitors, so it could be. It's this class, and the recommendation is for children. The best is what we know more. So it's just a new. Medication. We don't have a long study. I mean, and so I will not go for the first treatment for that. It could be useful if we have a severe glaucoma treated already and there is no other possibility. But I will not go to a new one for children for the first line. That's just the thing. And it's not so obvious in adults also. For ROCK inhibitors, the results are not so good that we are hoping.
I had just a small comment on that one. They cannot really be nasty for the epithelium in the grown-ups too, that do not have the challenged epithelium from the very beginning, which these patients usually, or in general, do.
I had the same comment that I think intolerance would be a problem there. What is your experience in children, Professor Bremond?
Well, the intolerance for all the kind of medication or ROCK inhibitors, yes, it's not so easy. Not so easy. Would you like to talk also? No, nothing. No, all right. No questions.
Just something that I remembered
Perhaps
now.
just small experience with Auckland, for example. My experience, say, can increase risk for dry eye. Also, a lot of the patients who take it complain about irritation. So it would probably not be my first choice to try for aniridia patients, especially not for children.
I think we all agree, so you have your answer.
I was just wondering, it just came to my mind about glaucoma. There was a study, I think a few years ago, they found nicotinamide as a biomarker for glaucoma. And actually Maria didn't show, but in our metabolomics study, we did find that the patients had lower nicotinamide levels. I don't know if there's been any follow-up on those studies, if any of you uses, because it's a form of vitamin B3, if I'm not mistaken, right? But then I don't know if there was any follow-up from
There's
those.
a big clinical trial going on right now for that. Yeah.
But as a treatment or as a
treatment?
preventive?
No, as a treatment.
Okay.
Yeah.
Okay. Yeah. Good.
Back to the disease management for children, because you brought the example of the girl of 17 years old. I think this is quite frequent, and it's more over a comment, and maybe we need your experience here. You see often these kind of cases when kids and families are reaching doctors that are not well trained and prepared to manage aniridia. Let's keep it here, and they are acting and taking decisions that are life-changing for them, like operating cataracts, like a normal cataract. They are treating the cataract as it is, a cataract, isolated from the aniridia context. Same with the glaucoma and many, many others. Do you see, and which is your advice for the national associations here?
Exactly, good guidelines. We usually talking with patients and families about the guidelines and about what to do, but we have a lot of patients in doubt especially if there is a first case in the family. And I still talking about the families, to make stronger association, because actually Poland has no strong association, because it's much easier. We usually do this kind of patient appointments one day to make exchange their experience with other families, with other children. And but the problem is that we have had some cases which say, we would like to talk with some other center, but we are the only center in Poland, so we sent to Hamburg actually, and they came to Hamburg. They listened the same, and then they came back and still were in doubt and still looking for somebody who will tell them something better, not just bad things about aniridia. And the problem is that you always find somebody. We are laughing that if you have a good insurance, they can operating your flu. So it's like this. And finally they found, because I really remember this case. I know this girl, maybe 7 years. She was 10 years old, I think, when she first time came to our center. And they were still unsatisfied with our diagnosis, with our treatment, because there was nothing, just, there's drops, and we tell them no surgery, everything is okay, and there was no worsening, there was a stable. But they expecting us to increase visual acuity, for example, and other things. There was a slightly cataract. In my opinion, it was, we didn't recommend the surgery, but Nóra said today about this. Now we are thinking when to do the cataract as well, because it's easier, and it's when it's not an advanced cataract, and when we don't have any any AAK type 3 or 4. But from the other hand, cataract surgery is always, there is no 100% success even in patient with not aniridia. So we are always really careful with that. So we now more and more discuss with patients and the families. And in children, as Dominique said, is a special group of patients. We are really carefully, and we don't want to experiment as well. And so that's why I think I always recommend the second opinion, maybe from or also reference center, like Hamburg is the closest, I think, to Poland, so many patients is coming there. But what is the saddest thing is this patient coming back and beg us to do something. There is nothing to do then. So I'm really unhappy for Monday, because there will be really difficult talk with the family and with this girl. And I think we have a good experience because of cost, our association. We have a lot of friends who is doing that. And I always asking somebody what to do to make another opinion. But surgery is always a big challenge. And I prefer to wait, but this is my personal opinion. But sometimes maybe it's not good choice. But especially in children without any other symptoms, we don't recommend.
If I may, just a comment. It is normal and human that families look for solution. And the hard thing is to understand that there are no easy solutions, and sometimes no solutions at all. This is why we created the associations. And this is why every year in every country where there is an association, we have a national meeting. We bring doctors and experts in aniridia to talk with families and to answer their questions. This is what we have been doing for 2 decades so far, and we always promote new associations as much as we can. So this is what we are trying to do as patients' representatives, and I would like to express my gratitude to you, because this kind of talks we are having, like in this conference and the previous ones, and all the work about the guidelines and everything, it is really so helpful for patients, because it is expertise in professionals is continually growing, but also expertise in families must grow, and we are all committed to this, and we try to do our best. And so thank you so much for being here and for all the time and dedication you give to aniridia and aniridia related issues. Thank you.
I must add something. Thank you for the associations. Thank you for Aniridia Europe, because we need you. It is very important to diffuse the information, and you have a very great role. So thank you very much also.
Thank you. Reflecting on all this, I know that it is really difficult that you can, all of the things you say, it is you as experts from your experience, you can make a decision. Having in mind that for many, each patient, if we can save each patient's life in terms of, they just keep their life quality as it is, not make it worse, we have made success. And in Aniridia, it is really each patient, because they are referred to, doctors that are, in many countries we don't have centers, so they have contacts with local and normal doctors, if I can say normal doctors, sorry. But what I want to say is that it would really help if there is a way in expressing recommendation at this point, because we know since the last 10 years, since 2012 with the conferences, it is always what we know today, and this changes over the time. We have learned a lot. So but somehow before finding this, I know that all the decisions need to be based on research and on facts and so on, but you really have a lot of experience as well. So I'm just asking a question, because it's sending out. If it is possible to have, without having facts, it is at the moment, this is how much we know, that also could help in many cases to not to make a wrong decision. Now I know that this goes completely against the ethics and the, everything that you work with and stand for, but we're talking about the rare disease and the importance that the latest information and what we know now can reach different actors, stakeholders. Now, this is just an open question.
It's a great open question, of course, but we are doctors and we do evidence-based medicine.
Of course.
And of course, it is complicated to say, okay, change your style and do it what you think. That's why we have consultation and we can discuss with patients. And I think this is based on it, and that's why it's important. But we cannot say like this, the recommendation is this, without any publication, any evidence-based. I don't know if you agree, but I will not do that. And I think the best is discuss with an expert in your country, and it will be probably very valuable.
I think that underlines that's why we need guidelines. That's why we should all follow those guidelines, and no matter to what centers a patient goes to, hopefully he gets the same recommendation. So that would be nice.
I think there are always evidence-based medicine and not evidence-based medicine, and we have two ways, and the patient also has two ways to choose. So it always be like this, and we sometimes hearing about some therapies which is totally, I don't know, from the moon, I think. And so that would be every time when we are finding a solution, especially when you are a parent, and So we do, as Dominique said, evidence-based medicine, and to get this evidence-based medicine, we need a lot of research, a lot of patients, and sometimes we do wrong decision, but it's also decision, and it's also wrong experience is always experience. So that's what I say.
And yes, I totally agree. And if I may add something, you know, this process of, you know, trial and error takes time. So sometimes it's difficult, you know, to make someone who is, you know, who has a real problem such as this one, that it takes time. But in terms of, you know, consensus and perhaps guidelines, I think it is important to have you patients, you know, part of this, because this shouldn't be like top-down guidelines. Someone was telling today that perhaps in some instances, you know, visual acuity is not the principal problem, but it may be another one. And, you know, I acknowledge that as ophthalmologists, we are taught by the very first day that vision is the most important thing. So that's natural that we, you know, go over it. But sometimes it may just not be the only thing. So I think this should be acknowledged.
So Galina has a question.
First of all, I would like to say big respect to you, Dr. Werba, because your country has no patient association, but you are doing since many years, like we know each other, such a great job. Like I can imagine one of the country who has very strong patient association. So you do, you put on your shoulders a lot, and you keep going, being very humble, very, let's say, so in a special way with patients and with the doctors. So this is big respect to you. And another thing, in one of the Aniridia Conference, Dr. Raymond, I think, he said, of course, Aniridia is genetic disease, and we all pray for our geneticists. Like one day they will find cure for the Aniridia. But at the right moment, what we are now, hoping for this bright day, we all clinicians, our main goal to keep the health of our patient in the best condition we can. So this is what you are doing, guys, and also big respect for you. And I hope geneticists, you will find the cure in one day. So thank you very much.
Thank you very much for a great discussion, and thank you for another great day. And I think we have free time now, and let's see on the dinner at 7.